So we're going to talk about the evaluation and management of osteoporosis, including both non-pharmacologic and pharmacologic measures. Okay, can you guys hear me on that side? So I might gravitate towards one set of slides. It's just easier for me to see this set. But let me know if it becomes a problem. All right, how do we define osteoporosis? There's a couple of different ways. Purists would like the pathologic definition, which relies on just decreased bone strength. That's really all we're talking about when we're talking about osteoporosis. And the importance of this is that it results in the clinical outcome, which is fracture, that we're trying to avoid. It's a little more difficult, actually, as a clinician to define it, because we know the bone mass part. You know, we're very used to bone densimeters and finding bone density and defining osteoporosis that way. But that is less than 50% of what accounts for your fracture risk. Right now, that's what we can measure. We can't really measure microarchitecture. So bone mass and density, how much bone is there? We can answer that question, grams per centimeter square. We can't tell you, does that bone line up properly? Is it a mess? And that makes a big difference in your fracture risk. You can figure that out with bone biopsies, which most of us aren't doing. There are some non-invasive tools that are coming down the road that may help us figure out this very important bone strength piece, but we don't really have that widespread right now. Those are just some pictures showing what good bone and osteoporotic bone looks like. So most of us go by the World Health Organization definition of how we define osteoporosis. This was established around 1994 for some historical perspective. It was not meant to be a clinical score. It was meant for research purposes and epidemiologic purposes, and that's been translated over the years into thresholds for treatment, but that was not the original intention. So we consider a T-score of -2.5 or worse, typically at the spine or the bone, to be a definition of osteoporosis. And what that means is your bone mineral density is at least 2.5 standard deviations worse than the bone mineral density of a healthy 30-year-old who happens to be your same gender and nowadays your same ethnicity. Seems unfair to compare everyone to someone who has peak bone mass at age 30, but that is what predicts fracture risk, how far away you get from that ideal peak bone mass.
That's for both male and female.
That is for both male and female. It's a great point, though, because these definitions initially applied to postmenopausal white females. Since then, the database has grown. It's not as strong in terms of predicting fracture risk for everybody else, Asian women, men, but it's what we have. Great point. All right, scope of the problem. It is the most common metabolic disease. Obviously, we're not seeing quite as much of osteomalacia and Paget's and other things that make up my practice. 10.2 million folks in the US. About a third of all postmenopausal white women, if you look. And let's not forget the men. 2 million men. Age is the biggest risk factor for osteoporosis in men. Osteopenia, which just means milder degrees of bone loss by bone densitometer, affects up to 50 million folks in the country and over half of all postmenopausal white females. What about fractures? This is what we really care about. We're looking at about 2 million osteoporotic fractures per year in the US. And in terms that make it a little bit easier for me to understand as a clinician, that's about half of all white females and about 20% of all men over 50 are going to have at least one osteoporotic fracture in their lifetime. That does not necessarily mean the worst one, hip fracture, but it means some type of osteoporotic event. Age, again, is the biggest risk factor for sustaining a fracture like this. This pie chart over there is supposed to remind us that about half of the fractures we're looking at are vertebral compression fractures. Not all of them are clinically apparent. Some of these are just radiographic fractures that are kind of the risk factor for going on to develop a hip fracture. So it's kind of a bad thing if we don't know about those. A quarter are wrist, and then a quarter are hip fractures. So this is a question I get a lot from medical students, residents. Yeah, okay, you might get a fracture. What's the big deal? It's not like a heart attack. It's not like a stroke. There's a lot of impact to vertebral fractures and hip fractures. If any of you guys have taken care of folks, and I'm sure you have, who've had these events. People who suffer vertebral fractures, particularly multiple ones, get spine deformities, chronic back pain, and then they're on pain medications, which again causes more falls and causes cognitive issues. You can get respiratory and abdominal symptoms if you have severe deformity of the chest cavity. And then for hip fracture, the big thing is you lose your mobility. That is what is so important to our community, ambulatory, elderly folks doing well in their home. So after hip fracture, about half of folks are going to need help. Does that mean there's kids, their grandkids now have to take time off work to help them. Does that mean they move in with their kids? It's a really big issue, even if they don't go on to develop full institutionalization. The complications are what accounts for some of the mortality, particularly in men. So when you're immobile, your DVT risk, your PE risk, pneumonias, things like that can set in. The mortality numbers, I think, are pretty striking. A one-year mortality figure of about 40% for men with hip fracture and about 20% for women. So the take-home there is men who have hip fracture do die at higher rates than women. There's probably some confounding here. You know, who gets hip fractures? Probably sicker, older folks who can't recover from them. But even when you correct for some of these confounders, you're left with a pretty high mortality. And of course, the cost is high, about $20 billion a year. So sometimes, you know, my eyes glaze over when we start talking about numbers of dollars and events. So sometimes it's useful to pit things against things we're more used to thinking about. So these are cost of hospitalizations for fractures compared to other, quote, major chronic diseases. So everything I've highlighted there are different kinds of osteoporotic fractures. The different color bars are just different years. And then over on the right-hand side is the MI, stroke, and breast cancer costs for hospitalization. So if you look, you know, really once you're getting into hip fractures and distal femur fractures, the costs are comparable to the cost of hospitalization for an MI or stroke, and sometimes even greater. All right, so this is what has bone specialists and endocrinologists all riled up, a so-called crisis in osteoporosis care. I thought this was kind of an interesting article. It was written in the New York Times, I believe, earlier this year. Suggesting that drugs' rare side effects have caused millions to take their chances with osteoporosis. So what side effects are they talking about here? So everyone's worried about osteonecrosis of the jaw, and what else? Excellent. Atypical femoral fractures. Okay, so my job is not to tell you not to worry about these things, but my job is also to remind all of us that typical osteoporotic fractures way outweigh these very rare, very uncommon things that occur in folks who have been on high doses for long periods of time. Usually it's cancer patients or your women who have been on these drugs for many, many years. So there are patients whom we need to think about these risks in, and I'll talk to you about how to recognize those folks. But just remember, the number needed to treat is so small for high-risk patients to prevent a real osteoporotic fracture. Do you have an idea what % of folks with hip fracture in this country are on an osteoporosis drug as of 2014? You think it's 25, 50, 75? All right, 25, it's even lower. It's about 3 to 4% of folks in this country who have had hip fracture as of 2014 are on an osteoporosis drug, which I think is just criminal. I mean, it was never very high anyway. We got up to 15, 20% rates about 2007 or so, and when this thing hit, it's just plummeted. And the same is true for all osteoporosis figures. Probably appropriate in some cases. You know, a lot of us were just putting everybody over age 50 on a drug, which was totally inappropriate. But a lot of the plummeting is unfortunately in folks who really deserve a drug. We would never let someone leave a hospital after an MI without a statin, beta blocker, et cetera. And these drugs reduce fracture risk by 30 to 70%, depending on what you're looking at. So I do think it's somewhat criminal that this has occurred. And you know, unfortunately, patients are scared, and it's really hard for them to tease out the risks and benefits. All right, so risk factors for osteoporosis. This is just, quote, primary. It used to be called senile osteoporosis. I really hate that term, but this means generally postmenopausal osteoporosis. Some things you can't change. We're all going to get older. Being female, white or Asians are at greater risk than African Americans. Family history, you can't change your genetics. Some of us make good bone, and we get great peak bone mass at age 30. Others of us do not. Early menopause, this is a big one. You know, some people just go through early menopause. We have a lot of women who've had surgical menopause in their late 30s. They're thrilled not to have periods. They don't get hot flushes, and they don't get estrogen for those last 10 to 12 years where they really should. And that's a big deal now that women are living, thankfully, into our 80s and beyond. Modifiable stuff, people who are sedentary. Excessive alcohol is more than 2 drinks a day for a woman, more than 3 for a man in terms of bone. Tobacco smokers, I've highlighted that one because that's yet another reason to get folks to stop smoking. Low BMI, low body weight's interesting. It's not really BMI so much as body weight, interestingly enough. So folks who just happen to weigh under 130 or so, they're lifelong, even if they have a normal BMI and are otherwise healthier, are at greater risk. You're not going to tell your folks to gain weight just to avoid osteoporosis, but just know that's a risk factor. And then we're all getting less vitamin D, mostly because we're worrying about skin cancer risk and we work indoors all the time. So secondary, this is what I want you to at least look at some of these highlighted factors here. So major risk factors for secondary osteoporosis means what beyond your genetics and general lifestyle could predispose you to losing bone. Drugs are a major risk factor. Glucocorticoids are responsible for a whole host of problems, and bone loss is a big one. So these folks don't get recognized typically because they're heavy. You're worrying about a million other things like their rheumatologic disease and their pulmonary disease, and you forget that they can fracture because they just don't look like a little old frail lady who's going to fracture, but they do. Medroxyprogesterone is Depo-Provera, great means of birth control. Sometimes you have to use it, but women who use it, girls who use it, don't reach their peak bone mass and are a great risk for osteoporosis later on. The risk for fractures has not been established yet, but just know if you have alternate means to try and think about that. Thyroid hormone has a very narrow therapeutic index, so we're often over-treating folks. Chronic narcotics, I think we're all aware, can cause hypogonadism in men, and then through that same mechanism can lead to some bone loss. Proton pump inhibitors, this first came out about 10 years ago, 15 years ago, associative studies. You need some acid to absorb calcium. So again, if a patient needs a proton pump inhibitor, they need it, but make sure they're getting enough calcium and hopefully taking their calcium in the morning at least half an hour before they get their proton pump inhibitor on board. So I won't go through all of these. The most important thing for you guys to remember, I think, is if something looks unusual, if it's kind of a young woman, a heavy person, a non-white, non-Asian person, a man who has osteoporosis, you may want to dig a little further, grab a table and start thinking about some of these risk factors. Do they drink alcohol? Do they have occult celiac disease? The endocrine metabolic stuff is pretty rare, I think, in the general primary care world, but they are predisposing risk factors. So who do we screen? Like all other screening guidelines, it depends on who you ask. The USPSTF tends to be the most conservative. The National Osteoporosis Foundation tends to be more aggressive. Generally, most people agree that women who are 65 and older ought to be screened, because if you screen these folks, at least 10 or 15% will meet criteria for treatment. So there's a good chance that you will change your management if you screen them. Men, this is a little more controversial, but several organizations do suggest the chance is high enough that you ought to screen men over the age of 70. You may be more selective in that if you choose, but this is a general guideline. And then what about folks who aren't quite that old? So postmenopausal women in their 50s and early 60s, men who are younger than 70. The thought is that you should think about screening folks who have risk factors. There aren't really any scores to help you decide who those people are. It's not like Framingham scores, so we're kind of left a little bit on our own. I think most of us would agree if someone's been on prednisone 20 milligrams a day for years and years, and they're 60, I would probably screen them. If they have lesser risk factors, it's hard to know who to screen. Insurance will cover it, though, as long as they have one risk factor, as well as being over this age. We screen with a DEXA, typically of the spine and the hip. You'll get a score for the spine and the total hip, and then you'll get a score for the femoral neck, which is just part of the hip. It tends to have lower scores, but remember, osteoporosis is a systemic disease, so you just need a bad score at one site to meet criteria for having osteoporosis. Have any of you ordered specifically DEXA scans looking at the wrist or the distal 1/3 radius? I see some yeses. Some radiology groups routinely do that. Ours do not. So the distal 1/3 radius is not as great a predictor of osteoporotic fracture as the other two sites. But the wrist there is composed of what's called cortical bone, more so than trabecular bone. So that inside bone, the spongy bone, that predominates in the vertebra is trabecular bone. That's where we lose a lot of our bone right after menopause, and then the cortical bone comes later. But if you've got certain syndrome, particularly hyperparathyroidism, yet another epidemic, based on calciums being checked on BMPs probably, you're going to lose distal 1/3 radius or cortical bone and perhaps hip bone more than you will vertebral bone. So if you're looking for an indication to send your patient to parathyroid surgery, you probably want to add on that one site. Sometimes you just can't interpret the spine. Folks who've had multiple fusions and surgeries, the spine's useless. Don't do it. Just do the hip and pick a second site. What about VFA? Does anyone know what a VFA is? Vertebral fracture assessment, good. So again, some people, I don't think people are routinely getting these. I think you still have to ask for it. It's just basically an x-ray that's done at the time of the DEXA scan. It's a nice way to look for occult radiographic fractures. Okay, so there's, again, a lot of guidelines as to who you should get a VFA in. I definitely do it in anyone who's had substantial height loss. So height loss is generally considered 1 to 1.5 inches over a lifetime, or if you've been seeing them often and you're seeing a little bit every couple of years, that qualifies also. Because if you find a radiographic fracture, even if they don't have, quote, osteoporosis on their DEXA scan, that's an indication to treat that patient because they're at high risk for getting a subsequent fracture. Other reasons you could consider getting a VFA, basically osteopenic patients who are at high risk of fracture, something to think about. So diagnosis, pretty simple, 2.5 or worse by T-score on your DEXA scan. Or if you've suffered a fracture already, you know that person has poor microarchitecture, even if they don't have poor bone density. The clinical dilemma is most of the fractures in this country occur in people who don't have, quote, osteoporosis. They have T-scores of -1.5 and -2.1. Osteopenic, it's just because that's such a bigger pool of people. You know, there's so many people out there with osteopenia. So we will talk about which folks with, quote, osteopenia should you consider drug therapy in. All right, so let's go to evaluation. This piece is not that long because there's not that much to do. So we all do a good history. Definitely ask about fragility fractures. You'll have to phrase it however you want to phrase it. People don't know what a fragility fracture is. We consider a fragility fracture when you fracture one of these sites, the hip, the spine, the wrist, from a standing height without much trauma. So, you know, if I was reaching for something, I fell down, fell off a curb, fractured one of those sites, that's a fragility fracture. If you were in a car accident, if you fell down several flights of stairs, probably wouldn't call that a fragility fracture. But you still may want to ask about their true fracture history. Have you lost height over your adult life? So I say, if I met you when you were 30, do you remember how tall you were? How tall are you now? Ask about those risk factors when we gave you that table of modifiable and unmodifiable risk factors. And then ask about drugs, the same ones we talked about. Symptoms and signs of some of these endocrine diseases are difficult to ask about. You know, symptoms of hypogonadism other than loss of libido, there's nothing that specific for them. I do always ask about stones. You know, folks sometimes forget, I don't know how they forget about it, but they forget about a stone that they had 3, 5, 7 years ago. It's important to ask about so you know whether to screen for hypoparathyroidism. Exam is also pretty focused. You know, other than their BMI and weight, you're basically looking at a good standing exam. You want to see them walking. You want to look at their spine. Do they have any kyphosis, which is curvature of the spine? Cushingoid features. This one you may say, well, that's such a rare disease, which it is. True Cushing's is pretty rare. I see a lot of it, but most folks in primary care are not going to diagnose it. But remember, in very large databases, Europe and here, up to 2 to 5% of folks with type 2 diabetes actually have endogenous Cushing's syndrome that we're missing. There's a lot of subclinical Cushing's out there that can contribute to metabolic syndrome and that can contribute to fracture risk. So again, central rate's a really hard thing to go by. We all have central weight at some point, but the more specific signs are noted there. Similarly with hypogonadism, particularly with men, gynecomastia, decrease in body or sexual hair is very unusual for men later in life. So labs. When people come in with postmenopausal osteoporosis, I see a whole gamut of what types of labs people do. Some just do a calcium and a creatinine and treat. Others do everything. The basics are what's listed here. We go ahead and recommend a CBC because certain paraprotein disorders like MGUS are so common, particularly in women over age 60, so it is recommended to go ahead and do it. The bone labs, calcium, creatinine, phosphorus, magnesium are pretty simple. LFTs, not that high yield, but they sometimes can give you a hint of a person with occult disease or occult celiac disease even. Vitamin D is, I don't have to preach to any of you guys, it's just being probably over-tested, but in this situation, it's appropriate to test for vitamin D. Alkaline phosphatase. Why would we measure alkaline phosphatase? I mean, I hear Paget's, and that's a thought. That's a good thought because, you know, if you have a person who has low BMD, Paget's doesn't initially predisposed to low BMD, but if you have a patient who has high alkaline phosphatase, you do need to think about Paget's if everything else is normal. And then hyperthyroidism can contribute. The other ones are things that I don't routinely do. If I'm seeing someone for something else and I happen to think about their bones, if they're referred to me, a patient whose bones are getting worse or people can't figure out why they have osteoporosis, I generally will do a 24-hour urine calcium. About 10% of folks with osteoporosis have what's called a urinary calcium leak. It's not apparent by the serum calcium level. Sometimes you can have an abnormal high PTH that makes no sense because their vitamin D is normal, their calcium is normal, they're really easy to treat. People with urinary calcium leaks typically are spilling over 300 or 400 milligrams of calcium per day into the urine, and a low dose of thiazide can correct that. So I have seen a number of folks who that's the primary reason why their bones are not improving with standard treatments. And then the others, things like PTH, I don't recommend routinely getting them because you're going to get a lot of falsely, slightly abnormal PTHs that you then have to chase. So if the calcium's normal and you don't have a person who's had cortical bone loss or kidney stones, I would leave that one alone. In men, I do go further, particularly the younger a man is. I will check morning testosterones. I will ask about alcohol. I may screen for Cushing's if someone has signs and symptoms. If they have occult GI symptoms, sometimes we'll do tissue transglutaminase and look for celiac panels. This is just a reminder of what the scores are. So normal bone density is considered a bone density that's no more than 1 standard deviation away from that 30-year-old gender-matched, race-matched person. Osteopenia is 1 to 2.5, which is a huge range. It's a lot different to be minus 2.4 than to be minus 1.2. Okay, so just recognize this is a spectrum. All right, so I know you guys can't see the specifics of the DEXA report. Do any of you look at DEXA reports just out of curiosity? I see some signs. Yeah, so I mean, as an endocrinologist, it would be pretty embarrassing if I don't look at my own DEXA reports. But you know, sometimes you're doing a lot of other things and you just kind of skim through the scores. It's almost like looking at an EKG and just looking at the printout and not looking at the quality of the EKG. You yourself don't have to feel comfortable looking at the quality of a DEXA scan, but certainly your radiologist should or whoever's performing it. A couple of things I want to point out about a report. The first thing is that it's supposed to tell you what machine it's done on. So I think this is GE. We use Lunars. There's also Hologics. Why do we care what machine it's done on? So I hear subsequent, baseline. Yeah, you're all thinking the same thing. There is a lot of variability from machine to machine. There's a lot of variability in the same machine. Our DEXA scan in our endocrine clinic, we are constantly doing quality measures on it. We have to submit these reports every year so that you know you have adequate precision and accuracy. So the best way to get someone's bone density to change is to send them down the street to someone else's bone densitometer because it will be different. So when you get folks who have been tested for years and years, they move to your vicinity, they get tested on a new machine and it's different, you may want to get the old reports and look at the actual, not just T-scores, but the bone mineral densities, the grams per centimeter square, and you might see it's been 0.89 forever. It just happens to show up differently here based on their normals and their controls. So it is important if you can, we don't always have the luxury, but if you can to do them on the same bone density scanner each year. Then I personally look at the quality of the images, you know, just a little shift one way or the other, and all of a sudden you've got a totally different bone density score. You'd be surprised how many times in that L spine that they're including a T-spine. Sometimes the entire frame is shifted upwards or downwards. Same for the hip. If you can't see a little bit of that lesser trochanter there, it's not rotated enough. It's hard to get people to rotate properly to these DEXA scanners. So again, you don't have to know how to do it, but if something is amiss in your scores, go back and either look at it or have someone who knows what they're doing look at it to make sure that there's good quality control. And then the third thing I look at is the actual bone mineral density scores, the T-scores across the sites. Is there someone that's totally aberrant? You know, if L1 is way different from L2 to L4, the interpreting person should have thrown out L1. But if not, that's something to think about. And the last thing I look at is just the trends. You know, usually a report will give you pictorial trends over time. But even if a score is, quote, bad, if it's been that way for years and years and years, you're probably not quite as concerned that there's a new secondary factor you have to explore. All right, so who should be treated? I've kind of hinted at this throughout the way. If you've had a fracture that's osteoporosis fragility fracture, you've ruled out and or treated secondary causes, I think this person is ready for a bone drug. If you have an osteoporotic T-score, if you have a T-score that's -2.5 or below, they probably ought to be treated. Patients sometimes ask me, what does this mean? So every standard deviation below the mean that you have is associated with an additional doubling of fracture risk, again, compared to a 30-year-old person who you hope is not having osteoporotic fractures. So when you go from -2 to -3, you get a 4-fold versus an 8-fold risk of fracture. It's hard to give people numbers that mean something, but this is one attempt at doing so. And then the third group of folks who should be treated is folks who have a 10-year probability of having a hip fracture that's over 3%. So our threshold's really low. You know, we don't want people to have hip fractures. This is based on cost-effectiveness data. You can argue the threshold, but that's what we have. And I'm sorry, this is a typo. Any major osteoporotic fracture over 20% by the Frac tool, not 10%, okay? Because major osteoporotic fracture includes things like wrist fracture as well. So these are, I won't say they're not arbitrary thresholds. There are reasons behind them, but they're not 100% set in stone. You as a clinician can decide that even if a person doesn't meet these scores, that they have such a high risk based on one thing, maybe very high steroid use, maybe very bad family history. You can certainly make your own decisions, but this is what guidelines currently call for. So who should you be doing a Frac in? We don't really have to check a Frac score if you don't want to in someone who has a T-score of -2.8 because they've already met indications for treatment, right? You can still do it in a young woman, a 53-year-old woman who has a T-score of -2.6. I'll sometimes plug it in because I just don't think that woman's going to fracture in the next 5 to 7 years. And it's helpful to counsel folks, as I said, who are relatively young. Have most of you visited this Frac site or seen it? Used it? Okay. If you haven't, I encourage you to just play with it. I think it's just instructive for us to figure out who's really at risk for fracture. There are definite limitations to this. This is kind of the bone world's first attempt at risk stratification scores. There are others that have come down the pipeline. The nice thing is if you go to this site, I mean, you can really just type in fracs.com. You have to pick your country or continent, and you have to pick your gender of your patient. Make sure you pick properly. It'll affect your Frac scores. And then you have to plug in a few things. Okay, so I usually it's just an icon on my desk screen, and the patient and I plug it in together. And sometimes it's useful for the folks who aren't sure if they want to be treated, who you're not sure if you want to treat. And you still don't have to treat, but you've got a baseline risk score that you're looking at. So you do put in all this data, age, sex, weight, height. It'll convert it for you if you don't want to do your kilograms and centimeters yourself. The hardest thing that I find to put in is number 10, which is secondary osteoporosis. That's kind of a diffuse thing. What do they mean? You know, if the patient's been on thyroid hormone for a long time and sometimes their TSH has been 0.3, is that secondary osteoporosis? Yes, no. The good news is whether you check that box or not, it doesn't make that huge a difference. It doesn't really add that much to your fracture risk, and you can play with that and see. Which one of these parameters do you think, other than the T-score itself, makes the greatest difference in what your risk comes out to be? I hear something over here. So I hear the femoral neck score itself. So yes, I would agree that putting in a very low BMD or a very low T-score will affect your fracture risk a lot. But other than that, number one, age is the biggest thing. So if you just pick a patient or pick yourself, pick someone you know who's over the age of 40. This does not apply to people under 40. And then put in the same T-score and just keep adding age. Make them 45, make them 50, and it is just phenomenal what age does to your fracture risk. And I think that will help us, and it helps the patient recognize, look, I have a really bad T-score, but I'm 52. I don't want to be these drugs forever. I'm active. I'm probably not going to fracture, but maybe we'll repeat my bone density, and when I'm 62, clearly at that point it might be a good time for me to consider these drugs. All right, so that's all on evaluation. We'll move on to management. Okay? So non-pharmacologic measures. These are not really exciting, sexy things to talk to patients about, but they're really important. Okay, so how can we strengthen bones? To be honest, most of this is preventative. The people who you really want to talk to this about are folks who are busy talking to about a billion other things. You know, when you're young, you're not thinking about your bones too much. But that's your biggest impact, getting people to peak bone mass. And that should say calcium 1,000 to 1,200 milligrams a day, not 2,000. I apologize. So the calcium recommendations have changed on and off over the years. The Institute of Medicine issued some new guidelines a couple of years ago. In general, we want people to get it via diet if they can. There's a lot of calcium-rich sources of foods that you can get it in. It's probably absorbed better, and there's less of a risk of hypercalciuria that way. So this is really a situation where more is not better. I have folks in the supplement world who love to take 2,000 of calcium, 3,000 of calcium. They're so worried about their bones. They're just going to pee it out and get kidney stones, and that was shown in the Women's Health Initiative trial. And there's also some concerns about coronary calcification. That came out a couple of years ago. So make sure they're getting adequate calcium, but they don't need to get extra. Vitamin D, again, lots of ways that you can supplement this. People's needs vary. People's absorption varies. I've seen folks on as much as 5,000 a day, and I've seen folks on none who do fine with just their sunlight. And there's not much of vitamin D in the diet. But generally, levels in postmenopausal women who were in nursing homes, that's where we have most of our data, getting the vitamin D above 35 did reduce fracture risk. We don't have fracture risk outcome data with vitamin D otherwise, but if you're treating somebody with osteoporosis who has low vitamin D, they're at risk for hypocalcemia and at risk for other problems, so get the vitamin D up. Exercise, anything that helps give resistance to the bones, walking works. Swimming's not that great, actually, for the bones because it's not anti-gravity. It's good for a lot of other things. So get some weight in there. If they're older, frail folks, you just have to make sure it's safe weight-bearing activity, chair activities, resistance bands, you name it. And if they can stop smoking or stop drinking too much alcohol, that's helpful. How do we prevent falls? Well, I think you guys know this probably better than I do, but really impress upon your patients the importance of a good environment at home. Address sight and sound issues, address walking issues. Polypharmacy is a big one. I can't tell you how many fractures I've seen of folks who were already on drugs like Neurontin, were given a little bit of Ambien to help them sleep, and the next thing you know, they've had a fracture. And then any balance exercises are also helpful. So now we have pretty much the rest of the talk to talk about drugs. Okay, so this table is a little bit busy. You're going to see it again in various forms for consistency. I've listed drugs kind of as the ones that are approved for osteoporosis. PMOP in that fourth column means postmenopausal osteoporosis. The class or the mechanism is in the second column, so there's not millions of classes like there was for the diabetes drugs we talked about yesterday. There's just a few new ones to talk about. How you administer them, and cost is a really big issue for some of the newer drugs. It can be tough getting teriparatide, denosumab covered, although they're very effective. So I've bold-faced some of these drugs because the ones in boldface are the ones that we have fracture efficacy data for the hip. Okay, so it doesn't mean the other ones aren't good. All of these will increase your bone density, and all of them have some data for reducing vertebral fracture. But not all of them have data for reducing hip fracture. Part of that is because it's hard to find high rates of hip fractures in some trials, but part of it is they're probably just not efficacious that way. And of these agents there, number 5, teriparatide, recombinant PTH, is the only anabolic agent we have on the market. So all the others reduce bone turnover, but not many of them on their own will build bone. Teriparatide will. Okay, and this is, again, just a reference table showing you those exact same drugs. Again, this is for postmenopausal women. These are not head-to-head trials necessarily. The big thing to remember is this is very dependent on the study population. So who do we think is enrolled in drugs for osteoporotic fracture? Folks who you think are going to have an osteoporotic fracture within the confines of the trial. So we're not enrolling 53-year-old postmenopausal females with T-scores of minus 2.2. These are all women typically over 65. Often you had, I shouldn't say often, regularly in some of these trials you had to have vertebral fractures to get into the trial. So some of the early ones of alendronate, the study of osteoporotic fractures. So bottom line is these are high-risk groups. But when you treat high-risk groups, you get really impressive improvements in spine and hip density. About a 50% improvement in your vertebral fracture rate. So if you've got a high risk to begin with, dropping that by 50% or more in the first 1 to 2 years of treatment is pretty impressive. And then for hip fracture, the drugs that have hip fracture data, which is basically alendronate resedronate, which is your Fosamax actonels. You've got great hip fracture data for zoledronic acid, which was Zometa and is now reclassed when given for osteoporosis, and denosumab, which is Prolia. That third column, non-vertebral fracture, is a little bit confusing for people who look through studies. It basically means everything that wasn't a vertebral fracture. So there's some hip thrown in, but there's also some wrist thrown in. There's some distal radius thrown in. So that's not quite as good an endpoint as hip fracture itself. This little thing at the bottom I think is important for clinicians also. What do we consider clinically significant change? When you're following folks with their bone densities and it looks like there has been a blah, blah, blah % loss, the radiologist says, and you say, so what does that mean? So generally, if you've lost about 3% bone density at the spine, that's considered clinically significant, and about 5% at the hip. Each bone densitometer is a little bit different. There's something called the least significant change that's included. So it can be a little bit more tricky than that, but I think those are good general guidelines. All right, so this is the only mechanistic cartoon I'll show you because I actually don't like tables. It's easier for me to think about drugs in terms of how they work. So this is a very simple scheme of a bone formation unit. We all have osteoblasts that make bone every day, and we all have osteoclasts that break down bone every day. I tell my patient the osteoclasts are the Pac-Man cells. They're very important to get rid of old bone and then you lay down new bone. We do that really well when we're young. As we get older, we don't lay down new bone as well, and when you lose estrogen, you really don't lay down new bone as well, so the balance gets shifted. Okay? So it kind of makes sense that most of the drugs we have on the market target that osteoclast. Most of the drugs reduce osteoclastic activity. So the reason they're stabilizing or improving bone density is because you're not resorbing as much bone. It's not that you're necessarily laying down anymore, but you're shifting that balance. Okay, so that's your estrogen, your SERMs, calcitonins, bisphosphonates, denosumab. Teriparatide, I said, is the only one, a PTH analog, that directly stimulates osteoblasts and helps build new bone. There is something called osteoprogerin, which is something that competes with this agent called rank or rank ligand. That will be coming down, hopefully coming down the market in the next couple of years. It's a target right now, but we don't have any drugs that are OPG agonists just yet. All right, so we will move down the list. Estrogen. Is anyone using estrogen anymore for osteoporosis treatment or prevention only? No, none of us are doing that. We do use it for other reasons, obviously, but for lots of reasons, we're not using this as a primary treatment. So estrogen suppresses the osteoclast by suppressing this thing called rank ligand. That's an important thing to remember. We'll come back to rank ligand when we talk about denosumab. It also does actually stimulate the osteoblast to some extent, which I didn't list here. Estrogen is good for a lot of things. You know, it doesn't take much. A little bit of estrogen, even given via a patch, which is pretty safe to younger postmenopausal women, improves climacteric symptoms. In the Women's Health Initiative trial, there actually wasn't a coronary heart disease risk when people were just given estrogen. So folks who don't have a uterus just need estrogen. They don't need the progestin part, which is kind of interesting. There's been many analyses and reanalyses of that trial, which I don't have time to go into, but generally safe in some populations with regard to CHD risk. The cons, of course, is estrogen in any form can increase your risk of DVT, PE, gallstones, and the big thing we all got scared about was the coronary heart disease risk, particularly in folks who were given estrogen and progestin. In this trial, it was given orally, which is not the way I typically give it, but that was the way the trial was set up. But when you looked at it, the data down the road, it actually didn't look as bad in subsequent years. The people who really are at high CHD risk are folks who are given estrogen way after menopause. We really try not to do this. Why you'd give a woman who's never had estrogen at the age of 65 or beyond oral estrogen for the first time is not a good idea. That is probably a thromboembolic inciting procedure. Breast cancer risk, again, was seen. So the bottom line here for estrogen and osteoporosis is we don't recommend using it for osteoporosis alone. If you're using it for other reasons, you know, younger postmenopausal women who need it for their symptoms, you're certainly going to be maintaining their bone, and you probably don't have to worry about adding on another agent unless they're at very high risk for fracture. So calcitonin is one of these that if you're using, I'd suggest consider not using it anymore. You know, I had a couple of stragglers who were on this just because they didn't want to be on bisphosphonates. They didn't really have anything else to give them. Calcitonin is just a mimetic of a natural hormone that is kind of the anti-PTH hormone in our system. The main pro of the calcitonin is that it can be analgesic. It just makes you feel better when you've had a vertebral fracture, so it can improve pain in the short term. That's really it. The cons are that it doesn't work very well. It's very low potency for improving bone density. The data's very poor. There's a lot of potential side effects. It was withdrawn from the European market a couple of years ago and is now considered last-line treatment for osteoporosis by several organizations, and really only was approved in the first place for women who were over 5 years from menopause. So there is this concern about a possible increase in cancer risk that the FDA added in 2013. So it's not that it's necessarily bad, but it definitely probably isn't good. It's for producing fracture risk. So I don't really use it anymore. All right, so raloxifene. So here's a drug I do use. I use it more now than I used to, interestingly enough, because I've become much more comfortable with it. It's a selective estrogen receptor modulator. And all that means is it acts like estrogen at certain places, i.e. the bone. That's good. It acts unlike estrogen in other places. The bone there, that should be that's a typo, obviously. So it's an estrogen antagonist at the uterus and breast. And that's good, because we don't like estrogen-like activity in the uterus. That predisposes to dysplasia. We certainly don't want estrogen-like activity at the breast in postmenopausal women. So what's good about raloxifene, also known as Avista? It's a pill. You just take it once a day. It's pretty easy. It is available in a generic. And it's associated, this is not an FDA indication for it, but it is associated with a 50% reduction in invasive breast cancer. So it's a cousin of tamoxifen, which is obviously used in adjuvant therapy for breast cancer. So in my young postmenopausal women who do need something and don't have a lot of risks for raloxifene, it's a good choice, especially if there's a family history of breast cancer. Cons, we don't have hip fracture reduction data. We have the Moore trial, which established its efficacy was vertebral fractures. And again, that's what your younger postmenopausal women are probably going to suffer from. If you have really low bone density in your 50s and early 60s, you're much more likely to get a vertebral fracture than a hip fracture. But you can get more hot flushes, so people don't like it if they stopped having hot flushes and they start getting hot flushes again. You can certainly have DVT or PE. So my folks who take this, I do recommend that they stop it a couple of weeks before a major period of immobilization. If they're flying across the world to China, if they're having a major surgery, and that is written there as well. And there has been some incidence of increased stroke in very high-risk women. It was just one trial. It was older women, and there were some issues with the trial, but I do take it seriously. So there's my bottom line. Consider raloxifene for younger women who have low bone mass, but who haven't fractured yet, particularly if they have a high risk of breast cancer in the family. You have to be honest and say it is not FDA approved for breast cancer reduction, but there's good data for that, who aren't at high risk for getting estrogen. Okay, so it's a nice way, I think, to get people through the early postmenopausal period. So here's first line, bisphosphonates. I think we all have a lot of comfort or at least familiarity with these. The drugs that are available are listed for us, 3 orals and 1 IV form. Bisphosphonates are simply incorporated into the sites of bone remodeling. So they get into the bone and they stay there. They result in inhibition of both osteoclast function and survival. So you get death of these osteoclasts. The pros that they work, we have a phenomenal database for these drugs. They've been tested since the 1990s in hundreds of thousands of women. They're pretty cheap if you're talking about the oral generic forms. That shouldn't say Part A, it should be Part B covers the IV form. So cost is an issue with the IV form, which is zoledronic acid. It can be upwards of, $1,000 per infusion. However, most of the time, if it's office-based or infusion center-based, it's not covered under the drug plan. It's covered under the other part of the plan. So it's oftentimes covered if it's put through properly. The cons of the oral ones is that they just don't get absorbed well. One thing I tell my patients is try and improve adherence, because adherence is notoriously low to these oral medications. That even if you take it perfectly, you drink that full glass of water, you stay upright, you do it once a week, you don't forget it, most of it, 98% of it, is essentially excreted through the GI system. You're just absorbing about 2% of this pill. So you really ought to take it. But people don't feel better when they take it. It's not one of these drugs that has high impact factor like a statin. So adherence is very low for these drugs in the oral form. We'll talk about these rare but severe risks. And you can't really use these drugs once you get to low eGFR. And this is a problem because our CKD population has bad bone. They have bad bone for a lot of reasons, not just osteoporosis, and we don't really know what to do with people with advanced CKD. But in general, with eGFRs under 30 to 35, we're not supposed to use bisphosphonates. And I list the fact that they're long-lived in bone as both a pro and a con. You know, it's a pro because you can take these drugs for a couple of years, get great fracture risk reduction, and potentially stop them for a while. And we'll talk about what that means, that, quote, drug holiday. But the con is they're long-lived in the bone. So if you want to stop it because you're worried about one of these rare risks like the jaw necrosis or atypical femoral fracture, you know, I get calls from oral surgeons all the time saying, I know your patient's on a bisphosphonate and I wouldn't need to do this procedure. I'm going to tell them to stop it. I said, good for you, but the drug's still there. So it's really a conversation to have before you get to that point. So bottom line, because of the efficacy data, because they're very affordable in the oral form for those who can take it orally, they are still considered first line for most people who meet criteria for treatment. Okay. Does any of you guys have questions about the bisphosphonates? Because I think this is an important drug that people feel comfortable with.
I'm still confused about the duration of therapy.
So you're confused about duration of therapy. You should be. We're all confused about duration of therapy. I have a couple of slides at the end when we talk about monitoring and duration of therapy, but since we're here, I'll just say it now. In general, bisphosphonates, oral bisphosphonates, if they've been on board for 3 to 5 years, and probably more on the 5-year end of things for orals, and you've had good bone mineral density increase and stability over time, and the person's not fracturing, that's when most of us will take the person off a bisphosphonate and watch the bone density and watch them clinically. And about half of those people are not going to lose bone in the next 5 years that they're off the bisphosphonate. About half of the people will start to lose a little bone, and at some point there may be threshold for reinitiation. So it is a different situation than antihypertensive, anti-cholesterol medications, things you get on and you stay on. It's a constant reassessment of risk. The IV bisphosphonates, probably after 3 years of zoledronic acid, if they're stable or improving on their bone density and they haven't had fractures, you can probably stop it at 3 years and reassess. Okay, so we don't have randomized control trials of folks who have stopped drugs to say that these people do as good as the folks who haven't stopped drugs, but we have lots of long-term data of the extension of the original trials and what happened to the women who stopped drugs versus not, and that's what this data is based on. Does that make sense? It's at least one guideline. Yeah, question?
Switching from a bisphosphonate to like Evista.
Yeah, so the question is, how about switching from a bisphosphonate to a Evista? So there is very little data on sequential treatment, particularly in that direction. There's data on estrogen to one of the other drugs, but there's not a lot of data on sequential treatment. But if it's somebody who you want to give them a break from their bisphosphonate, they haven't had a fracture, so you feel comfortable doing that, but they kind of started out at a minus 2.9, and it just makes you nervous. You know, you don't have data, but it makes you nervous, and it makes them nervous. There's nothing wrong with switching them. You know, if you move them to a SERM, or like a Vista, they probably won't gain additional bone density, and I cannot tell you what will happen to your fracture risk, because we just don't have the studies for sequential treatment, but it's certainly some way to help them hold on to that bone density if you want.
Those are concerned about those fractures.
People who are concerned about those atypical femoral fractures, exactly. So hold that thought, because I do want to tell you a little bit more about those rare risks, because we should be able to counsel our patients. Yes?
All the orals equivalent. There was some early information that said that some were better for vertebral, some were better for hip risk.
Yeah, so the question is, are all the oral bisphosphonates equivalent? Some are better for hip, et cetera. Yes, so ibandronate, which is Boniva, I don't really use it because it really doesn't have non-vertebral or hip fracture reduction data. It doesn't mean it's not good for it, because it does improve BMD to a similar extent, but we just don't have the hip data. So I really limit my treatment to the 2 orals, Actonel and Fosamax, which don't really have differential fracture risk reduction. Risedronate or Actonel tends to, quote, work a little faster. You see the BMD increase a little bit more in 6 months. You see the fracture risk reduction a little bit sooner, maybe at the 6-month period than the 12-month period. And conversely, Actonel or Risedronate may leave the system a little sooner than alendronate, than Fosamax. Whether that's clinically relevant, nobody knows. So I personally don't think it matters whether you choose. If you're going to choose an oral bisphosphonate, I don't think it really matters if you choose Actonel, or if you choose Fosamax. Okay. Yes. Question.
Given your comments about the oral, are you using more reclass yourself?
Yeah, so comments about the oral, am I using more reclass? So I'm actually still using a lot of both. I tend to use a little more IV just because I'm a referral practice, so a lot of folks are referring to me because they don't want to give IV reclass in their office, or they don't have an infusion center. We do it all in our office. So if I'm worried about adherence, certainly if people have GI contraindications to the bisphosphonates, I will just go ahead and start with reclass. But I have a lot of nervous folks who say, I don't know if I want to be on it. I know you think I need to be on this drug. And the orals do tend to leave the system a little sooner than the IVs. Some people are just more comfortable with a drug that's not around for a whole year to 18 months. So I say we start with orals. And then sometimes we'll just transition to IVs once they're comfortable with the drug because convenience factor. But I wouldn't say efficacy-wise you have to go with IV because it's more efficacious, because those aren't head-to-head trials, even though the vertebral fracture risk reduction looks so good with IV data, with IV drug. Probably a lot of that is just absorption and adherence. Okay, so we got one more question, then I'll move on.
Do you follow bone markers early in the hospital?
Great question. So do I follow bone markers? Does anyone here follow bone markers? Bone turnover markers, I see a couple of hands. So there's no right or wrong. You can just know what it means. Bone turnover markers are things like urine, N-telopeptide, C-telopeptide. There are serum markers. So if your patient is taking the drug that they're supposed to take and they're absorbing it, they will go down by about 50% at 3 to 6 months. So it's sometimes useful for adherence. Some people, if they see that something is happening, because I'm not going to check a DEXA scan for about 2 years, it makes them more excited to take their drug. I check bone turnover markers in folks who aren't getting the bone density improvement that I think they should be getting, because if they're still high, then that's a problem. Unfortunately, you can't do that in hindsight. If you don't have baseline, it's not that useful to get it later on. That's the problem. So if you're going to use it, think about getting a baseline and moving on, but you don't have to use them. Okay? So I'm sure there are more questions. I'm going to move on to get through it, and I have some more management-oriented pieces. So how do you initiate a bisphosphonate? I think you all know this. Just make sure their calcium, creatinine, and vitamin D are checked and are normal. I'd mentioned reason to consider the oral drugs first line because they're cheap and we have great efficacy data. The 70 milligram dose is for alendronate. Risedronate I think is a 35 milligram once a week dose. There's also a monthly way to give risedronate, like 2 days in a row, once a month, whatever you and your patient like. And then I do consider the IV drug in these following situations, which we've already kind of mentioned. If they have GI issues, difficulty adhering to weekly therapy, it's generally a 5 milligram dose. It probably stays around for 18 months. So if you're doing this yearly and you're getting to the 3rd year and you really want to continue giving it for 5 years, you can probably get by with spacing that infusion out 18 months or beyond. It's clearly been shown even in trial settings. And this was the question that someone had asked, is there a difference between the two oral bisphosphonates? There may be slight differences mentioned there, earlier onset versus greater cumulative BMD gains, but I don't think there's really any clinical significance to that, so I probably don't start drugs based on those 2 issues. All right, so here's the ugly picture that we keep seeing, osteonecrosis of the jaw. So let's talk about these 2 rare but concerning side effects. So osteonecrosis of the jaw, of the 2, has the weakest link with bisphosphonate therapy or with anti-resorptive therapy. That means it's been seen, but it's typically been seen people who have been on high doses, IV drugs. They were first seen in cancer patients, because remember, a lot of these drugs were approved for hypercalcemia and Paget's and metastases from breast and prostate cancer well before they ever got osteoporosis indications. So that's who was using these. Oncologists were giving monthly IV at the time called Zometa for other purposes, and that's where these reports first came out. These numbers may, again, make your eyes glaze over, but these are really small numbers. In some studies, higher rates of ONJ was found in the non-bisphosphonate users than in the bisphosphonate users. The risk factors are listed there. So before you start a drug, just make sure you have good oral hygiene. Ask the patients, are they planning to get major root canals in the next 6 months? If so, hold off on treatment. Smokers, diabetics, glucocorticoid users, and people who are of Asian descent typically have a higher risk. It never dissuades me from starting a drug, but patients are going to ask you, so this is what you have to tell them. Atypical femoral fractures are also very rare, but they're actually more clearly linked to bisphosphonate use than ONJ is. Okay? There are some very specific criteria for how you diagnose an AFF. And in general, the median use for folks who've gotten AFFs are about 7 years of use. Oftentimes, in my experience, it's upwards of 10 years of use. The risk factors are people who are smaller femoral shafts or angles, again, glucocorticoid users, diabetics, and again, Asian women. So in the years that I've been doing this, I've seen 2 people with atypical femoral fractures. One was Asian. Both of them had been on the drugs more than 7 years, more than 10 years. One was a patient I wasn't even treating for osteoporosis. I saw her for something else, but we admitted her with that. So both of these things are far, far less common than the risk of osteoporotic fracture. Okay, so if you're starting a drug in someone for good reasons, they meet criteria for starting, you really shouldn't worry. You, as a clinician, shouldn't worry too much about this. Your patients will. You're going to have to counsel them, and hopefully if you have a good therapeutic relationship, they understand that you're not just going to put them on a drug and let them go for 20 years. You know, you're going to keep reassessing them. You're going to decide if they need to come off the drug, and that's honestly really the best you can do in that case. So some scary pictures, even though I told you don't worry about it too much. The picture on the right is kind of a subtle early formation of the AFF. You see that cortical bone on the side? I don't know if you can appreciate, but it's really white. It's thick. That's kind of what happens in folks before they get the AFF. That's the full-blown AFF. It's also called a subtrochanteric fracture because it happens under the trochanters. That's not where your typical hip fracture occurs for people who have osteoporotic fractures. So pictures like this are very scary, and even if it happens rarely, when you have one of them, you feel awful. So the one I admitted, for the next 6 months after that, everybody I started on bisphosphonate, I was just nervous because we're going to remember the really bad outcomes as doctors. All right, so let's move on to denosumab. This has been on the market for a couple of years now. This is a completely different, I'm sorry, question? No question? Okay. Completely different drug than the bisphosphonates. It's a monoclonal antibody that binds rank ligand. Remember, rank ligand is on the osteoclast and promotes osteoclast activity, so inhibiting this is a good thing for the bone. It works really well at all sites. It's comparable to the most potent bisphosphonates, meaning reclassed. You get greater BMD gains. I'm not talking about fracture risk, but if you just keep following these people's bone mineral density, it continues going up. It's convenient. You just dose it twice a year subcutaneously. There's no infusion. It's usually well tolerated. So I put down there for Medicare patients it's covered by Part B if it's given in the office or an infusion center. But there can still be lots of issues with payment. And different plans can give you problems with it. We have a prior auth person in our office who makes sure it's covered before we give it, and even then we still have problems. So not enough time to go into all the ways you can get around the cost, but it's real. The cons are that you lose bone mineral density when the drug's discontinued. Okay, this is not the same as a bisphosphonate. So then you say, what, am I supposed to continue it forever? I don't know. We don't have studies forever. We have studies for about 5 years to 10 years of this drug. So that's the big question. What do we do? Can we keep them on it forever? Maybe, but I don't know that right now. The cellulitis and dermatologic reactions in the studies I haven't really seen, but that is a concern for some patients. ONJ AFF have been reported for this as well. It just hasn't been around as long as a bisphosphonate. So we'll probably see any anti-resorptive, we're probably going to see reports of ONJ and AFF. So it's a good alternative for those at high risk of fracture or those unable or unwilling to take bisphosphonate or have failed bisphosphonate. Dr. Rubin in our group, who is our bone specialist, is actually using it as primary treatment for osteoporosis in some cases. I am not yet doing that. But in general, this is who the folks I recommend you use it in. And then finally, teriparatide. This is Forteo. It's been around for a long time. It's hard to take. It's an injection you take once a day for 2 years to build bone. It's just an analog of PTH. So PTH, when given intermittently, builds bone. When it's chronically present, like in hyperparathyroidism, you break down bone. It's an anabolic agent. It restores microarchitecture, not just BMD, which has been shown in studies. There is a possible role for this drug when you get an AFF. So a patient, the most recent patient I admitted, we actually ended up using Forteo. There is some preliminary data. It may help heal it. The cons include some minor effects like nausea, pain. You do get hypercalcemia if you measure it too soon after the injection, so you don't measure calcium for at least 16 hours after an injection. There's a black box warning for osteosarcoma in rats, not seen in humans, but again, lots of folks who have MGUS, history of breast cancer, we're really not supposed to use it for right now. You can only use it for 2 years. And again, this is the big one. If you put your patient on this drug, or someone else does, and they take it for 2 years, and you've spent all that money and time to gain bone, if you don't do anything else, they're going to lose it. So if someone is contraindicated to get a bisphosphonate because of their creatinine clearance, you can't just say, we'll just go on Forteo for 2 years. You better have a plan afterwards. And the plan now can be Prolia. Money is a huge issue. So I use this for folks with very severe osteoporosis, people who have fractured, people who have failed an anti-resorptive. So a couple of last slides on just management issues. Sequential therapy sometimes can produce increase in BMD in the first year after oral bisphosphonate. And I've listed the different things that can happen there, but we don't have great data for it. So we're kind of left on our own for people who want to switch therapies. Combination therapy currently is not recommended. Some of these drugs might cancel each other out, and even if they don't, we don't have the fracture data. Romosozumab was just written about in the New England Journal this year. It will be coming out probably, but it is not FDA approved. It's an antibody that inhibits sclerostin, and if you do that, you get both bone formation and less bone resorption. So it's the first drug that does both. Really impressive fractal risk reduction at the vertebra. They didn't see hip reduction, so I think that's going to be a little bit of a bummer for that company. We really want hip fracture reduction. And even at 1 year, you saw 2 ONJ and 1 AFF. To me, that's pretty scary. We'll see how that translates. Teriparatide is another PTH analog that actually has hip data, which Teriparatide doesn't. So maybe there's a market for that there. And the last drug, unfortunately, I was excited about, but it was pulled from the market. Pulled from studies just a few months ago for stroke data. We've already talked a little bit about monitoring therapy. Generally, you do it with DEXA scans after at least 1 to 2 years, and then thereafter as indicated. You can use bone turnover markers. If they're not doing well, if their bone density continues to go down, or they fracture, look for secondary causes, maybe switch therapies. If they're doing well, then we consider what's called a holiday only for bisphosphonate users. So here's the rationale for a drug holiday. They're long-lived in the bone. They have good anti-fracture efficacy, at least for 5 years after stopping. We don't know beyond that. Do not do this for other osteoporosis drugs, and you can consider that if you meet these criteria. I've put those same criteria in box form for you. So 3 to 5 years for low-risk folks, 7 to 10 years for high-risk folks. Very few people should be on these drugs after 10 years, although I'll say in my practice I have a couple who are because they are older and they are fracturing, and I think their risk of fracturing is way greater than their risk of an AFF or ONJ.